My name is Adnan Siddiqui. I'm a professor of neurosurgery at State University of New York, University at Buffalo. We'd like to present recoiling of a giant posterior communicating artery aneurysm, which was previously treated with stent-assisted coiling. The patient is a 61-year-old female who presents with recurrence of a left posterior communicating artery aneurysm. This had initially ruptured 6 years ago, was treated with coiling, and then subsequently retreated in elective fashion with stent-assisted coiling. Now she has a significant recurrence at the neck. She has history of hypertension, hyperlipidemia, and is on aspirin. The rationale is simple. This aneurysm is previously ruptured, it has recurred, it has high risk for rupture based on rupture status as well as size and location. The treatment choices are limited because clipping a previously coiled giant aneurysm is complicated, especially when there's not adequate neck to clip reconstruct, and prior coil mass complicates visualization during surgery. Endovascular options include flow diversion, which are complicated because of the prior stent that has been placed, and putting a new flow diverter across a previously placed stent creates issues with endoleak. Therefore, the plan at this point is to proceed directly with primary additional coiling of the vessel rather than flow diversion. It is important to note that deconstruction strategies also remain viable by performing a balloon test occlusion and seeing if the vessel can be completely occluded. However, occlusion at the level of PCOM does compromise the risk to the anterior choroidal artery. The system for these cases, when it's primary coiling, is fairly simple. 6 French groin sheath, 6 French guide delivered over a VTK select catheter and an 035 wire system. And then we like the 0165 microcatheter with an 014 wire. In this particular case, we use hydrogel coils, given evidence to suggest that there's better occlusion rate with gel-based coils rather than bare platinum. You can see the beginning of the case where we have just established groin access with a femoral sheath. The VTK catheter is being used to selectively catheterize the left carotid artery. An angiogram is performed, which we use as roadmap to deliver the 035 wire to the distal internal cervical. This is video that has been sped up, and the 6 French guide is placed, and an angiogram is performed, and you can see the giant aneurysm with a significant recurrence at the level of the neck. A 3-dimensional rotational angiogram shows the anatomy very clearly there. With the catheter under higher magnification, one can establish clearly the neck of the aneurysm and the associated posterior communicating artery. Once we have that, it's best seen on the lateral view. We then use a microcatheter and wire to catheterize across the previously placed stent to introduce the microcatheter into the aneurysm sac, and you can see curling of the wire within the aneurysm sac. Sometimes the microcatheter can get stuck on the tines, and therefore it is sometimes useful to reestablish access to the aneurysm through a different tine, and that's what we are doing here. We've used the J to introduce the microcatheter into the tines, and then micro wire to advance into the aneurysm. And again, we are trying to continue to catheterize the aneurysm by using a different tine and a different access point. You can see in the left panel the microcatheter has been induced, and now we are bringing coils into the system. Once we are happy that the microcatheter has a stable position in the aneurysm, the coil has been introduced, and this giant aneurysm simply can eat up that coil. You can see the coil finding space in the large base, which is evident there. Best seen in the top right lateral view. The detachment zone is showing up, and the aneurysm is delivered, and then we continue to put additional coils in this aneurysm. And as is typical for giant aneurysms, there's always more space than you imagine when you're putting additional coils. An angiogram shows the aneurysm continues to fill. You can see in the left-sided panel, the assistant is getting prepared to deliver coils, and introduces the coils, and then the actual interventionalist advances the coils through, while other additional team members continue very careful observation of the microcatheter tip. You can see forward pressure is used to get the catheter in a much better position so it does not leave the aneurysm sac. Now, a lot of additional coils have been placed, and you can gradually see the difference in the previously placed coils, which are progressively reducing the amount of recurrence. At this point, it's important to understand the dynamics of crossing a stent with a microcatheter. Using a smaller profile, a softer tip can sometimes allow easier access. And sometimes you have to build the momentum and get the right angle. And most of all, when one tine doesn't work, reposition the wire and try the adjacent one as best as possible. Most importantly, the patient had an excellent clinical recovery, an overnight stay in the hospital, and 6-month digital subtraction angiography revealed no additional recurrence.